Well, good afternoon, everybody, and welcome to the GP PLT. Today's one's slightly different one, being hosted by Dr. Cathy Appleton, who I'd like to invite at the moment to get things started for us. So, Cathy, over to you.
That's great. Thank you, Craig. So I'll just get the agenda back up. So welcome everybody to our Wednesday afternoon PLT. We've got quite a full afternoon. Just to introduce myself, I'm Dr. Cathy Appleton. I was a partner in Woodsend and Wollaston for 30 years, and I'm now working as a GP lead for GP retention in Northamptonshire. So this afternoon we've got an afternoon where we're discussing GP retention, but also particularly in relation to the interface between primary and secondary care. So we've got an interview with Dr. Olivia Stevenson from Dermatology. We've got a presentation by Farouq Ololade, who is a GP working there to improve communication. And then after the tea break, I'm going to sort of talk a bit more about what's going on nationally on the interface. And we've got further presentations from Mr. David Payne, urologist, Amar Guri, who's the GP working with him, and Dr. Shadi Nafi in urology. And then we've got Emily Winters just sharing her role as the Associate Medical Director for Primary Secondary Care, and then a half an hour at the end for questions. So we're not going to have the chat on initially, so you can focus on the presentations. But if you've got burning questions, if you can write them down, and then you can pop them in the chat at 4 o'clock, and we'll have all of us on the chat. Apart from Olivia Stevenson, just to answer your questions. So just moving on. I started in this role 3 years ago now, and the first thing I did was sent a questionnaire out to all of you, and got about 130 replies. This was to investigate what was going on with GP retention in Northamptonshire. Already had a background of what was going on nationally, and it appears that we have two peaks where GPs leave, are most likely to leave. We have female GPs leaving at a peak of the age of 35, and some male GPs and also female, but significantly the male GPs leaving at the age of 60 or just before. So our questionnaire went out to GP registrars, salaried GPs, locums and partners, and we had a nice spread of ages responding, which was great. So what I wanted to know was what things were causing very high impact to your workload and your stress, and which things were causing low impact. So the graphs that follow, the things that are causing very high impact are in red, and high impact in orange, and you can see the lower impact things are green. So this is a very busy chart, but you can get the general idea. So the things with the most red, orange and yellow on are the things that are causing you the most stress. So at the top, we have got excessive primary care workload, which is no surprise. But what is interesting, actually what comes second and third, is excessive workload coming from secondary care and poor communication with secondary care. Also following that, we have got worries about medico-legal risk, and obviously how that interacts with excess workload is an issue, and concerns about regulation. So following forward, we've got those top three things that are causing you the most stress. So obviously, I had to follow up on that from the questionnaire to see what can be done in Northamptonshire to reduce that stress with our communication with secondary care. And that was how the Clinical Interface GP programme was born. So there's a picture of Kettering General on the left and Woods End Surgery on the right. And we have multiple communications going on between those two places, but we often never really know what's going on behind the doors. So we have recruited 5 GPs up to now. The first 2 started in September 25, and that's Amar and Farouq, and they're going to be speaking to you about what they've been doing for the last 6 months. And then we've just recruited 3 more GPs, so we've spread into Northampton General now, and new specialities at Kettering, breast and gastroenterology. So each GP has a named consultant mentor, and the GPs physically go in on site to sit with the consultants and their admin teams and have a look at the communications that are going to and fro. We pay the practices directly to release these GPs for 1 session a week. And although secondary care, there's no payment going to secondary care, and they're not contributing to the payment, they are contributing in the time that is spent for these consultants in mentoring the GPs and spending time discussing the issues that are coming up. So GP is acting as a bit of a conduit in those specialities, and they're reviewing the correspondence in and the correspondence out, and particularly looking at referrals and responses to those referrals. We're looking at requests for investigations or investigations that are requested to be done before the patient is seen, and whether those are practical or appropriate. We're looking at referral guidelines as they get to developed new pathways and guidelines. We're making sure that GPs have a good input into those, and similarly with prescribing request prescriptions coming out of secondary care. So we're hopeful that also this will lead to education on both sides, that we will understand each other's worlds a bit better and produce some more joined up working. So as I say, we're hoping to have improved communication, hopefully that we're going to get inappropriate workload reduced on both sides, hopefully therefore increase capacity on both sides due to that, and also give new opportunities for clinical education. The benefits to the GPs who are doing this, it's good for GPs, we know, in terms of retention, to have portfolio roles, so you're not getting totally bogged down in general practice all the time, and you can do something a little bit different for a session or 2 a week. So hopefully we're doing that for the GPs that are doing this, and we're hopefully going to have some impact on all of the rest of you. So the result of this, hopefully in another 6 months or so, is that we'll start to be communicating better and seeing each other as human beings a little bit more. So what we're going to do is Craig is going to lead us in now to a recorded interview with Olivia Stevenson, who's presently on holiday in Corfu. But she'll be back with us and working part-time from the end of the month, beginning of the next month, I think. Okay, over to the interview.
Hi, Farouq, how are you? I'm very fine. Thank you for agreeing to join me on this short interview. So, not to take our time, by introduction, my name is Farouq Ololade, and I'm a GP working with dermatology as an interface GP to see how best we can improve the relationship and communication with between primary care and dermatology. And I've got Olivia Stevenson here with me. Olivia, can you please introduce yourself for those that may have no that may not know you before? I've
Hi.
never
Yeah,
seen
thanks.
you. All right.
Thanks, Farouq. I'm Olivia Stevenson. I'm consultant dermatologist here at Kettering General Hospital. I've been here for about 21 years. I'm clinical lead and working really well with Farouq to get things a bit more streamlined. Really happy to get on board.
All right, thank you very much. Right, so over the last couple of months, we've been working together and we've audited a couple of advice and guidance together, routine referrals and 2-week wait. And we've identified that there are some challenges or some things that could have been better from both ways, from primary care to dermatology and same from the dermatology department to primary care. So this is what we'll be focusing on today to discuss about how things can be better. Can you just briefly tell us about the advice and guidance pathway from the dermatology point of view? What are the challenges that you've been experiencing with respect to it, with main focus from the referrals that are coming from primary care?
Yeah, thanks, Farouq. So, I mean, I think we'll have to accept that there's been a real challenge from the part of Kettering to provide a good service because we have had staffing issues and we have had up to 7 weeks delay on A&G, which is obviously completely inappropriate for patients to wait that long before getting advice. And we're really working hard to improve on that. And part of that is increasing capacity in the dermatology department, but another part of that is making sure that the A&Gs that we do get are useful, appropriate, and don't need to keep bouncing back for further information. So I think that's one of the things that the audit highlighted. There's a lot of things we could do to streamline that patient pathway, and so the A&G service is really there for anyone who doesn't feel that dermatology is necessarily warranted. However, obviously we can upgrade to a referral at any time as long as the referring clinician has clicked that little button that says allow referral. So I don't think you should be worried about using it when you're not sure if a patient needs to be seen, because if the patient needs to be seen, we can accept it. But in most cases then, and I think there's a tendency to move towards asking first, because in many instances, there may be a better pathway for a patient than direct referral into dermatology. But it does really rely on us making sure we've got the right information, and we need to have enough information to make a clinical decision, and we need to have some good images. And I think you've highlighted that in your audit that was a particular problem, didn't you? So for us, as long as we have a good history of the complaint, we want to have an idea of what the expectation is. Are you asking for advice or a diagnosis or both? Or are you asking for interim advice and then a referral? Because that's obviously also sometimes really, really useful. Just bearing in mind that we can only advise on what information we've already been provided.
Right. Okay. Yeah. And in terms of the information, what are the challenges that you've been having with respect to the history? If you can elaborate more on the history and the problem with the pictures that has been coming to you.
Okay, so I think the issue is that because we have such poor transition of information between primary and secondary care, we don't have easy access to your notes. I think there's sometimes an assumption that we know an awful lot more than you put on the paper, and of course we've got nothing. So I think it's really important that we have an idea of duration and evolution in any condition, whether it's a rash or a lesion. How long has it been noticed? What have the changes been over time? And what treatment have we already tried? And I think that's where we fall short, and we demonstrated in the audit time and time again that we will have bland statements like we have tried lots of different treatments, or we have tried many steroid creams, or we have tried all the available therapy. But that isn't helpful for me. How am I supposed to tell you what is next if I don't know what's already been before? So I think it's really important that we have really specific details on what exactly do you mean, what steroid did you use, for how long was it used, what was the response to that treatment, because a lot of the inflammatory referrals will be this patient has failed treatment with steroid creams, for instance. And there's also a really important thing. What does failed mean? Patients often tell you it's failed because it didn't cure them. Whereas all they mean is that as long as they use it, they might be all right, but then they have to continue using it, which is kind of to be expected. So I think it's really important to have specific details about what treatment's been used. And then on top of that, we have had a real issue with, obviously, some practices will favour patients providing their own images, which won't necessarily have been reviewed by the clinician. And so we do get 1, 2, 3, maybe even 10 or 12 images from a patient, many of which are either totally out of focus, not the area that was referred, or exact duplicates. So I think it's really important that we try and find a way of providing really useful images, which is basically just one of the whole area involved, one of the close-up, and preferably one with a dermatoscope if you have one available. And sending 5 or 6 images from a slightly different angle of the same lesion, it just slows us down uploading images and reviewing them. So I think that's been really, really insightful when you've seen that on the audit, haven't you, Farouq?
Yeah, I actually agree with that. Right.
Yeah.
Okay.
So I think, you know, also finding out what the expectation of that A&G is. What is it that we're asking? And realizing that there are certain things that we can't really help you with. So referring things that aren't commissioned, even for advice and guidance, we can offer a diagnostic support, but obviously we can't offer treatment guidance on non-commissioned services, such as benign lesions, viral warts, etc. So I think that's really been the main challenge with the A&G, really, along with the fact that, unfortunately, because we're so behind, we then have an issue with patients being re-referred in on top without the old A&G being cancelled. So that is duplicating work, because I will read an A&G and then realise actually the patient's got an appointment next week anyway. So that's been a waste of time. So I do think we have to maybe ask the admin team to help if there's something on the referral that suggests you've already sought advice from dermatology, that does need to be cancelled once a new referral is put in, I think.
Okay.
Yeah.
Right. Thank you very much. That is really insightful. Just to recap on that, is what you want on every advice and guidance as much as possible is a clear history. It doesn't have to be excessively long. Just tell us where the rash is or the lesion is, how it has progressed, how it has evolved, and has there been any changes over time. And equally, you want to know the specific treatment that has been tried, for how long it has been tried, and if there has been any response at all. And lastly, you want pictures, good quality pictures, in terms of 3 pictures majorly. One that is distance away to show the locality of the area where the lesion is, a close shot focus picture, and if possible, a dermatoscope pictures. Nothing more, nothing less. And then clarity about what we want, whether it is advice and guidance for diagnosis or treatment or both, knowing fully well that you will not be treating any uncommissioned work in terms of benign lesion. Now, that brings us to the next question. During the audit, we identified that there are some issues with premature referral for benign lesion, uncommissioned work, you know, even unavailable services, some services that you don't routinely offer, you don't have anything to do. Can you elaborate on that so that people can actually know that sometimes when they do refer these things, it's not like you didn't want to help, but you actually don't have anything to offer?
Thanks, Farouq. That's really helpful. So obviously, there's a relatively straightforward no benign lesion policy. I mean, there hasn't been a benign lesion service commissioned in dermatology for over a decade. There is a suggestion that we can accept lesions with prior approval, but I would say that 90% of those sorts of lesions that are referred in would be best dealt with in primary care surgical services anyway. It's very rarely that they're head and neck. We're talking about lumps and bumps and benign lesions. So I don't think they should be coming to us at all. We're so overrun with skin cancers. I don't think it's a good use of the service at all. We also have to realise that although we are happy to offer advice for treatment, there are, you know, limitations to what we can do. So we're not really treating conditions that are endogenous to a patient that aren't disease processes, like hirsutism and normal age-related alopecia, so too much hair, too little hair. You know, these are normally physiological for a patient. So unless there's a disease process going on, there's really not any involvement for dermatology. There are things that can be done. We talk about spironolactone, we talk about things, but actually there's nothing that dermatology can offer that can't be offered in primary care and that doesn't need the support of a dermatologist. We don't have access to any treatments that you don't have except in severe alopecia areata. So, but I'm talking about non-disease processes really. So sweating, for instance. There is a sweating service in Northampton for iontophoresis, but we don't have that service running in Kettering, and we don't provide Botox. So again, very little advantage of referring in for those sorts of things. So I think a lot of the time we have an issue with, because people know it's so long to wait, we have an issue where patients are initiated on treatment and referred at the same time. And I think that the trouble with that is that for advice and guidance, by the time I've got to that A&G, that might now be 4 weeks at the moment, I'm cracking on it, but it's still probably 3 to 4 weeks. I don't know what that response has been. You've already had a response to that treatment that you initiated, and I don't know what that is. So it's pointless me advising something else when what you've already done may be working perfectly well. And on the other hand, patients who come to clinic and say, yes, the treatment the doctor gave me has worked, it's gone now. And so patients either feel like they should keep their appointment just in case, or even they phone up the GP or us and are asked whether to keep it. And in general, they're told just to keep it. So, you know, I think referring prematurely is a bit of an issue, you know, before you've done the basics, because they know it's going to wait so long, really.
Right. Okay. And I think that also extends to eczema as part of what was eczema, sorry, acne. And you did mention there is no point referring anybody that is not interested in isotretinoin or retinoid treatment for acne treatment.
Yeah.
I think.
I mean, it is difficult. You chaps have an awful lot to deal with, and knowing the pathways for every single dermatological condition when there are so many is impossible. But I think the acne thing is a good point, because actually primarily acne is managed in primary care. You see acne, you know, an awful lot, but we get referrals for severe acne, but I think it just needs to be mentioned to patients because they're coming really for Roaccutane. And if they've waited 9-10 months and they don't want Roaccutane or isotretinoin, then what was the value of them waiting? So, you know, if you are really struggling and they really don't want isotretinoin, then an A&G might be a good option for you to say, okay, what should we do? But yeah, ultimately it's about that patient expectation again, isn't it?
Right. Okay. Thank you very much. And on the other side, when we audited the dermatology letters, we identified some areas where improvements, you know, can be achieved. For example, being clear more in the letter, clarity on dosage, clarity on what the diagnosis is, and what is the follow-up plan. Can you tell us how the department is going to work with respect to that to improve that moving forward?
Yeah, thank you very much, Farouq. And I think it's been really a good learning curve, because obviously we all like to think that we produce good letters, and sometimes we do and sometimes we don't. And I think moving towards AI typing will significantly help this, because it doesn't, when you have so many doctors and different members of the team providing letters, it's difficult to get them to follow a standard, even when you tell them to. So what we are looking to, and you are piloting, will be a standard letter that has, just like we're asking you of your referral forms, a standard letter out that will include the provisional diagnosis or the known diagnosis, what treatment they are presently on and what treatments they have failed, if that's relevant, and then what the plan is. And if we have that set in the template letter, it's going to be a lot easier for the clinicians to fill in the gaps. And I think that's going to help everyone, because, you know, patients then have a clear idea of what the plan is. The GP who's following the instructions knows what's going on. And also the next person who sees them in clinic, it's a lot easier for them to understand where this patient is in their patient journey. So I think that's, we're hoping to set that up pretty soon.
Yeah, okay. Yeah, we are definitely working on that. And hopefully by the time we audit, you know, after 3 months, that template hopefully is something that can be adopted in the primary care, you know, and secondary care as well, vice versa, so that that will help improve patient care moving forward. Right. I think we've covered most of the questions that I wanted to ask. The last thing I would say is, what are the resources that are available in dermatology that you can use to support primary care? For instance, the picture of a thing is a problem. we will try and work with our colleagues in primary care to see how things can be better. But in terms of dermatoscope, not all practices have dermatoscope. Hopefully, moving forward, some of them will be able to, or all of them will be able to have it. But is there anything that you can support primary care with in terms of learning? For example, taking a proper dermatoscope picture, one-stop clinic. Can anybody drop
Yeah.
in to come and,
Yeah,
just to
thanks.
improve our knowledge on dermatology?
Yeah, really useful. I think it is hard. We've all got a lot of balls in the air in medicine at the minute, trying to keep up with everything. We've always been really happy to accept GPs into clinic if they want to learn. We run a one-stop clinic every Tuesday where we see between 70 and 82-week weight. So it's a really good opportunity to see a lot of lesions. We see a huge amount of very typical seborrheic keratoses. And I think for any GP who comes, it's quite, eye-opening how much benign lesions we see, because once you have seen 5 seborrheic warts in a row, you can spot them as they walk through the door. I think that it's that repetition. So we've always done that. We used to run Skin Club. There hasn't been much appetite for evening meetings in recent years. I think people are too exhausted in the daytime, but that's something we can look at in the future. I think there is money out there in cancer funds for every practice to have a dermatoscope, and I just think every practice needs to be a bit proactive and make sure that they have one. I think the real problem is that if you have a practice dermatoscope and it's in some drawer in some office, then you're not using it regularly. And I think there needs to be, a much more easy availability. So I don't know, different practices run in very different ways, but there certainly needs to be one in every corridor that's running clinics, or and I suspect that GPs who have any special interest in skin at all should just have a dermatoscope to their name, really. I mean, they aren't a huge amount of money when you consider how much we spend on a lot of other equipments and unnecessary tests and all the rest of it. So I think that's really useful. There are incredibly useful resources through the Primary Care Dermatology Society. Now, I know you and I are very familiar with that, Farouq, and it's, when we're medics, and I know you all have that, you forget what's normal knowledge. You speak to your family about some, an aneurysm, expecting them to know what an aneurysm is. And it's the same in dermatology. I just assume everyone knows what the PCDS is, and of course you don't, but it is amazing, invaluable resource. It's pcds.org, and it's the Primary Care Dermatology Society. There is teaching, education and guidance on every single skin condition, disease, lesion that you can ever think of. And so if you're unsure, it's really useful just to check that link. And I know that you won't have time to do that for every patient, but when you know there's going to be a year's wait to get a patient seen, I think it's really worthwhile to familiarize yourself with the website, just because there might be 4 or 5 pages that you do continually refer to, whether it's the acne guidance or whether it's eczema, or I think that can be really, really useful. And there is also, information for patients on how to take a good picture.
Exactly.
And I think that link should be sent to patients so that, we tell patients, don't try and take it yourself in the mirror or behind you. You need to have someone else take the picture for you.
Right.
And we had an interesting conversation at your surgery, didn't we, Farouq, about admin checking the images, because I think, it doesn't need to be a medical person. You just need to, is it in focus? We all take selfies, 10 times a week. Everyone knows how to use a camera phone, and whether an image is in focus or not. And if it isn't, we have to straight ask for them to resend images, rather than wasting 5 or 6 weeks to wait for me to tell them that the images are no good.
Yeah, right. Thank you very. I think you've touched on very valid and important one, particularly on the PCDS. It's a very, very good resources for everyone. The picture link that can be sent to patient, I'll try and share that with during the PLT meeting as well. Hopefully, most of the practice will be able to adopt it and send it to their patient, so that moving forward, you'll be able to get good pictures and good history. Right. Thank you very much. I think that's all. You've been fantastic.
Thanks very much, Farouq.
Thank you for sparing your time with me today. And I'll feed you back on the outcome during our PLT. It's sad that you won't be able to make it, so that's why you had to do this recording.
Yeah, I'm sorry. I'm presently,
that,
touring around Greek islands. Sorry about that.
That's fine. Okay, no problem. Enjoy Greek island, and then we'll see when you come back. Thank you.
All right, take care, Farouq.
All right,
Thank you.
bye.
Bye-bye.
That's great. Thank you, Farouq. I can see that you've got some people have put a few questions in the chat. We were going to deal with those all at the end, but just for now, we will just move on to Farouq's presentation, if that's okay.
Hello, good afternoon, everybody. Thank you, Cathy. My name is Farouq Ololade. I'm a GP with Hussein Medical Center. I'm also the interface GP with dermatology, and I'll be going through a very short presentation. Actually, Olivia has said almost everything that is in my presentation. It's just going to be a little bit of re-echoing of what she has said, backed up with the data from the audit that I did while I was working. I'm still working there while working with Olivia. Let me just try and share my screen. Can we see the presentation now?
Yes, Farouq,
Yes,
just put it
yes,
on
we
to
can.
presenter mode and you're all good. That's
Okay.
it.
All right. Right. So introduction again. My name is Farouq Ololade. So the background of the audit is based on auditing the advice and guidance from GPs to dermatology, and we all know what advice and guidance is. It's just a way to communicate with specialists when we don't think a referral is outrightly needed, and this can help us to ensure that we get quick response to be able to treat our patients in a timely manner. The reason for choosing dermatology is because of the high referral volume that they do get and the specific delay with respect to their response, with respect to advice and guidance, and also because the dermatology department depends a lot on pictures, high quality pictures, to be able to make an informed decision or a proper advice for us to be able to manage our patient. And with the aim is the hope is that if we are able to get it right, there will be service efficiency both ways, and eventually translate to better patient outcome for our patients. So we set out with the aim to evaluate the quality and appropriateness and outcomes of A&G requests sent from GP to the dermatology department, and equally to evaluate the quality of responses we were getting back from the dermatology, as well as the time frame of getting this response back to the GPs. The objectives were to assess the appropriateness of the A&G request, i.e., is there adequate information provided in terms of history, treatment tried, and pictures, and also to look at the response time. How often do we get the response back? Do we have to chase them up and down before we could get to the timely response? And what is the outcome of most of these A&G, if almost all of them are resulting in referral, which means probably there needs to be something to change. But if the outcome is, they are able to give advice in most instances, then that will be the aim. That will have satisfied the aim of doing the A&G initially. The third aspect is to try and assess the impacts on primary and secondary care workload. This is quite a bit of a tricky one because it's difficult to judge by using a standard to measure how this is impacting, but just by estimating with the waiting time, the back and forth between primary care and secondary care, one can have an idea about how this has been affecting both both tiers of care, and also to see if there are areas that this can be improved moving forward, so that we as GPs, we are happy with our A&G that we are sending to them, and equally dermatology department is happy with the A&G request, and we are also happy with the response they are giving us in such a way that they are not giving us more workload than we are already experiencing. So we set out the standard. I think I followed what is on the GRIFT and British Association of Dermatology with respect to what is expected of an A&G request. So they expect that about 90% of them should have adequate clinical history, 80% of them should include relevant images where necessary, and at least more than 70% should be good quality image. And the standard response time is expected to be within 3 to 5 days, 2 to 5 days actually, with the average mean being within 72 hours. And also we look to see whether the advice given was clear enough to clear enough without any ambiguity and doesn't lead to any uncommissioned work. In the same way that we don't want to give dermatology uncommissioned work, we also don't want to get the reverse back from the advice that is being given to us. And hopefully to see if high proportion of the A&G were managed, without having to send the patient to dermatology face-to-face or converting it to a referral. So it was a retrospective audit spanning over a 3-month period, used a sample size of 300 and tried to randomly pick about 100 from each month. And data collected included indications for the advice and guidance, presence of quality images. We looked at the response time and then also look at the outcome of the A&G. Now, this is just a snapshot of what the result of the audit look like. So quite a good proportion of the A&G requests were mostly for benign lesions. For example, eczema, seborrheic keratosis, moles, actinic keratosis. There are quite a number of about 25% lesions that even the dermatology at the time they were giving the advice or responding to the A&G, they couldn't clearly say that, no, sorry, pardon me. So others like mixed pictures that could not really fit into a definite category, whether they are too small in terms of the percentages, they account for about 25% of them. There are about 8% of lesions who even the dermatology departments themselves could not even clearly say what it is. So it is more of a, well, we don't know what it is, or we suspect it's this. Can we try this and see what the outcome would be? But if we look at this graph, we could see that almost close to half, about half of the A&G requests are for things like eczema, seborrheic keratosis, moles, actinic keratosis, while a very small number will be for things like benign warts, hyperhidrosis, and acne. So that's the distribution of the results by breaking it down into the condition. Now, going to the quality of requests, specifically, if we look at this chart, what is showing us is that if we put 100 advice and guidance through from the audit, we notice that 77% of them actually had good clinical history that clearly dictates what we think is a problem, what treatment we've tried, and what we're expecting from the A&G request, while about 23% were devoid of either missing in adequate one aspect of the clinical history and all the like. Just above half, about 55.7% of them had good pictures that can actually be considered very good picture, even to a layman who is not a dermatology specialist. So, 27.3% of the A&G requests had very not so good pictures. Either it's too blurry, it's not focused, it's not showing which side of the lesion is, which is going to make it very difficult for anyone to be able to utilize that picture and the clinical history to be able to give a safe advice. And while 17% of them have no pictures at all. So if we group the categories with no pictures and poor pictures, it's running to about 44.3%, so which is a significant proportion given the fact that they rely a lot on picture qualities that we have supplied for them. In terms of the response time, yes, we heard it from her. They are way behind in terms of responding to the A&G request. The main response time was averaging around 6 weeks. I think it's better now. Hopefully, I think it's around 4 weeks now. But as at the time I was compiling this audit and doing this thing, it was around 6 weeks. Some can be early, maybe the range is about 2 weeks to 12 weeks. Some can stay for as long as 12 weeks before they get before we get a response back. And when I tried to look around what was causing this in those specific ones that were quite longer, so I noticed that fine, for one, they have issues of manpower in dermatology. There is shortage of manpower. It's mainly Olivia that was doing the A&G response, and she only gets about one session a week, which is not clearly defined time frame. Is it 2 hours? Is it 4 hours? Coupled with the fact that she has a lot of other clinical roles that she has to do. So sometimes she might not even get time to even look at it in a week. Now I think it's better. I think they've employed quite a number of people now who hopefully will be looking into the A&G. And when she returns as well, she'll be focusing mainly on responding to A&G. But as at the time we're doing this audit, they had significant shortage of manpower, which she also attested to. There's limited time that they spend on the A&G per week, and sometimes there is a lot of back and forth between primary care and secondary care. Okay, this picture is not good. Can we send us more pictures? Oh, I can't advise without the dermatoscope pictures. The history is not clear. Can you clarify what has been tried so that I can know what I can advise on? So those are the a few issues that I was able to identify that was partly responsible for the delayed in the response time. In terms of outcomes, analyzing the outcomes, actually more than 50%, about 64.2% of all the A&G requests were successfully managed by simply giving us advice. Only about 17%, less than 20% were converted into a referral by dermatology. In about 13% of cases, the cases were closed without any advice. Usually this is because if she has requested or they've requested for more information and the information is not coming back after maybe 4 to 6 weeks, then they close the case that there has been no response from primary care. And very little number, less than 5%, actually they escalate that to 2-week wait based on the information provided on the advice and guidance. So in terms of analyzing the response appropriateness from dermatology to general practice, notice that about 68% of the responses had clear action that could be followed through, no ambiguity. However, in up to about 30% or more, there are a lot of things that sometimes the advice is not quite straightforward. Maybe there is, for example, in instances where the duration of the treatment is missing, there is no clear-cut diagnosis, or what is the follow-up plan, what should we do if the treatment that they have recommended has failed. So which I've highlighted this to the dermatology department as well. So overall, the key findings from the audit was that majority of the cases were being managed without a referral. The quality of pictures that we do send to them is variable, ranging from good pictures to the not so good ones. There are incomplete clinical information in significant proportion. The response time is definitely not within target limit, and there are quite a number of responses that is going to be putting a lot of more burden on GP in terms of the inappropriateness of the responses or the request that they're asking the primary care team to do. So the next slide is more of repetition of the previous slide, so I wouldn't go more into this. Yeah, okay, right. So the recommendation would be that for us as GP, as much as possible, if we can try to make our request straightforward and simple by giving the dermatology team a clear focus history in terms of the duration, symptoms, and what has been tried, like she rightly stated, and giving high quality pictures. That will go a long way in ensuring that when they are triaging this A&G, they can respond faster and give us appropriate advice. For that, we are trying to pilot a template in Woodson Medical Center to see if that works, if that is going to change, the quality of referrals that we do send to dermatology. We are trying to do that for the next 3 months, and we're going to re-audit it and compare to what we have at the beginning, which is what I've shared with you. So we'll see if that works, and if it's something that other practices can adopt. That will be a discussion for a separate day that can be looked into then. The issue around pictures, I'm sure that's going to generate a lot of questions or discussions. Hopefully, we'll be able to have a meaningful conversation around that. For the dermatology department, propose to them to have a standardized response template, so which is clear enough. The response template will be good in two ways. It's going to limit or manage their workload for them. They don't have to spend so much time typing. If it is eczema, if it is they have a standard response template that they can send. And also it will help us in primary care. By the time you get standard response template 3 or 4 times for the same condition, then you understand what their own thinking is and the way they manage those conditions. Also, this template is going to extend to their clinic letters, for not just for A&G, for routine clinic letters, which is what she mentioned about in the video, to have a standard clinic letter, which will entail giving us the diagnosis, the previous treatment that the patient has tried, the current treatment, what has failed, what is the action plan for GP, and what is the action plan for dermatology. So I'm working with her on that. Hopefully we are able to get that done, get it up and running very soon. And also when she mentioned about all those services that they don't offer, for example, excessive sweating, iontophoresis and all the like. So they change some of their pathways changes midway that we are not aware of. So they need to give us clear guidance about A&G submissions, when things change, when their pathway changes, when the services they offer changes. They need to let us know as well, because we don't run the same system. So it's very easy to get lost in that field if we are not being properly updated about what is going on in their department. So they should also work on that. So that is the recommendation for dermatology. Overall, the action plan. So this slide is everything around this slide has been talked about, except mainly for the admin checklist. If possible, I'm thinking about maybe there is a way that the administrative team can help. I know as a GP, you've seen a patient, you write the letter and then send it to the admin team to send it over. But if there is a checklist for the admin team to look into what we have asked them to send and look at the pictures that the patient has actually sent, they can be able to see that, okay, is this pictures actually good enough? Will it not be bounced back? So that could be like a safety check both ways before from GP when we send A&G, and also for dermatology when they're about to send their letter to us. So there can be a checklist on both ways to ensure that all the things that needs to be there are already there. And if it is not there, they can easily flag it back either to the clinician or to the patient to ensure that whatever is needed is already is there at the get-go, so that it doesn't lead to back and forth. Can you explain on this? Can you give us more information? So that's the only thing I would say about this slide. So overall, just like a summary, what they want for their A&G and referrals is good history and good clinical pictures as much as possible. And in terms of pictures, she mentioned it, they only need 3 images, a macro picture, a close-up picture, and a dermatoscope pictures if possible, while avoiding duplicates of pictures in addition to the adequate history. So for example, this is a good picture that she referenced. So this is a distant picture showing clearly where the lesion is. It's on the shoulder and all the likes. This is a close-up picture to show a focused picture of what the lesion is, and this is the dermatoscope pictures of the same lesion. And so for example, so that is all they need with a good history, and they will be fine enough to be able to give us an appropriate advice. So yeah, so back to this one is where I mentioned what I mentioned about the role of admin. They are able to scrutinize referrals and ensure that the standards are met. They are able to look at pictures. They can send picture guide back to patient to retake pictures if the quality of the pictures are not met. And then they can liaise with clinician if necessary to include more detailed history if needed. So I think this last slide is just showing the link to PCDS guide on how to advise patients to take pictures if they are taking their pictures themselves, which also includes a video picture for patients on how to take clinical pictures. The last one is a video on how to use a dermatoscope to take pictures, and this is mainly for clinicians. I'll try and put all these links in the chat box if we are interested in it. Right, so by and large, that is it. In conclusion, A&G is variable tool in dermatology. A lot of the A&G, significant proportion are managed without a referral. There needs to be an improvement in terms of picture quality, clinical information from GP side, and also dermatology department working on the timely response and ensuring that their action plan is clear enough of any, clear of any ambiguity to primary care. Right. Thank you very much. That is the end of my presentation. I hope I'm in time.
That's great. Thanks, Farouq. So, as you said, yeah, that'd be great if you could put some of the those links in the chat. What we could do now, if you do have some questions coming out of that, if you want to pop them into the chat now, because we've got sort of we're starting our tea break 10 minutes early. So if you want to put those questions in, and then what we can do is possibly answer some of those questions just as we come back after the break, if that's all right with you, Farouq, and then we'll move on to urology. So yeah, pop your questions in the chat and go and get a cup of tea, and we'll actually come back at 2:40. So you've got a bit of time. Okay.
Also, just to let everybody know that the slides from today's presentations will be put on our website as well, on the PLT resources page. I will send a link out to everybody for that afterwards. I'll also be putting a link into the chat shortly, which will have a feedback form. If you want an attendance certificate, you would need to fill that in.
Great, thank you. Emma, did you have something you wanted to, you just pop your hand up?
Oh no, that was just accident. I was kind of reacting. I said I've tried to answer the first question I think that Julia had about the ozone contract, because that's I believe coming to an end next month. That was just a short-term measure as the ICB had some money left over. My understanding is that so hopefully they created a little bit of noise, but hopefully they won't be noisy for much longer.
That's great. Yeah, thank you then. So yeah, pop your questions in the chat, and we'll see you back at 20 to 3.